Welcome everyone to Policymaking and System Change Process. This is a three-part series, and it's really designed to strengthen and develop individual and organizational skills, providing them with competencies to formulate, shape, and influence public policy or create system change at the regional or national level. The way we're going to provide this is we will provide you with a 10 to 15 minute overview of setting the stage of the structure of how we're thinking about this. We have two panelists, which is Jose Francisco from PAHO and Charles Mullen, who's been part of the network for more than, I'm not going to age you, Charles, but a very long time and instrumental to its success. And then we're going to enter into sort of a brainstorming session where we invite all panelists to jointly design with us, because this is just the beginning of the stage of saying, how do we not only share great information through conferences and research and data, but how do we actually shift it towards actually moving governmental systems or healthcare moving forward. My name is Nicholas Torres, and I serve in two capacities. The first capacity is I'm the executive director of the network Towards Unity for Health, but I'm also a professor at the University of Pennsylvania at the Fels Institute of Government, which teaches social and public policy. So I will do that. And Charles and Jose, you want to do a quick introduction of yourselves, and then I'll launch into it.
All right, Charles Mullen. I'm now an independent consultant, but I have been working for the World Health Organization for about 30 years. And during my time at the World Health Organization, I had a special relationship with the network Towards Unity for Health. Actually, this was about 20 years ago when we thought that progress in the educational profession would be very difficult unless we create alliances with other stakeholders in the health system. And hence the concept of Towards Unity for Health. So I'm very glad to be part of that meeting, because I think it is quite appropriate to discuss about the social system policy issues and how we can make a difference at national, international level. Thank you.
Thanks, Charles. Jose?
Okay, my name is Jose Francisco Garcia Gutierrez. At the moment, I'm an advisor for the Pan American Health Organization on human resources for health development. But originally, I'm a general practitioner from Spain, that dedicated part of my life to public health and the health services and the reform of the health services in Spain and in other countries in Latin America and Eastern Europe.
So thank you. And for those of you who just joined us, there will be an option for you to collectively and co-design with us and brainstorm this framing into our 4 pillars. And when we do that, if you're able to, it would be great if you shared your videos as you talk, because this is being recorded, and then we'll use it as a tool to inform others. But launching into the formal presentation component of it, this is the first question that, when we tell people to say, if we want to make global change, but ultimately it becomes regional or national, there's a framework to think about whether the timing is appropriate to when to tackle a system or policy change or move it to the next level. And it's really framed within this matrix of saying, is the issue topical or non-topical? Or is the issue a priority or not a priority? And when we think of priority, we really think about who are the decision makers, and in a sense, do they actually care about it? Or maybe oftentimes they don't want to go there. But you have to consider what their perspective is, because without them, you can't necessarily meet the change. And topical also means that it's an issue that society as a whole may be talking about, and that's why we frame it within urgent. Or maybe it's not topical, it's not urgent. So the goal before tackling any policy issue or moving it into the upper levels is to try to get into the upper left-hand quadrant where it is a priority, the decision makers care about it, and it's urgent and or topical. And so then it has a lot of public attention, and you've increased your likelihood of actually making change. Versus if it's in the bottom right-hand quadrant, down here, where the issue does not have a lot of public support, the decision makers don't want to go there, then it's not as likely that it will move forward, and therefore you may spend a lot of effort but not necessarily make the changes you want. So the question for anybody who's really moving this is, how do you move into the upper quadrant? And so the process is what we're tackling today. Today we're really tackling upon, moving it towards how do you actually frame the argument so that policymakers or decision makers will endorse your idea and then move it forward. The second part of the series will be saying, once you've accomplished that, then we'll move into maybe how to make both the social and financial argument so that you're getting people towards on your side. And that actually includes this policy map, which is not addressed today, but will be addressed in the second part of the series, is to map out who are all these decision makers, both people for your proposal or against your proposal, and really put you in a stage of mediator for them, because you're trying to bring two different stages together to say, yes, it's important, we should move forward with it. The third part of the series is getting people to act. And so once you have people, in a sense, in the stages, you have to help them move them forward to say what action steps need to be made so that the issue is relevant and moving forward. So again, it is a three-part series. We're going back to just the stage today about setting the issue and the priority. So again, our process is, first part is our analysis, second part we'll do formation, third part is the implementation. Again, we frame the idea as we first figure out if the timing is correct, and if it's not, how do you move it to where it falls up into that upper left-hand quadrant, where it's a priority, decision makers care about it, it's urgent, and it's topical. So as we look at this sort of framing, when we want to make this, it behooves upon us to actually clearly articulate what that change is. And we have to, in a sense, write this out in what we would call a policy brief, so that the decision makers can read it, understand it, and then there's concrete action steps where we're asking them to do it. So really over here, we're saying, how do you do that? And the way you do that is you really have to study the issue. You have to go back to, what is the problem? Can you define it? What is the policies? And in a sense, the methods of analysis you've used to define the problem. And you have to outline who are the stakeholders and, in a sense, the politics behind it. Because even though ideas are great and we can all agree upon that we need to move forward with it, oftentimes other things get in the way. We have to understand that. Policy formation is articulating that in that policy brief. And then how do you make it work is really with concrete suggestions. So it's really the basics is, define the problem, which is a history. We would say define the problem within the context of social outcomes. Because ultimately what we're trying to achieve and demonstrate is we've improved the world for a larger society, and we need to show how that happens. But oftentimes when you're working with people within government and decision makers, whether in the health systems, you also have to define it in terms of what are the financial terms. Because there's oftentimes not more money but you can reposition existing money for that. So that's defining the problem. The second part of this is really, what is the specific goal? And this is oftentimes harder than we think it is. It's easy to say, what is your ask? What do you want policymakers, what do you want systems to actually do? And you have to make that very concrete. And even though we think it's not complex, it is complex, but we have to simplify it so people understand it and then move forward with that. So I'm going to jump into one U.S. healthcare case study so people can understand it, and then one international one about setting the stage and defining the problem, and then we'll move into the pillars of the TUFH. So the U.S. healthcare system saying, if we want to frame the issue, you have to frame it within an international audience. And so you can talk about how the United States has the highest health expenditures compared to many other countries around the world. And then especially when you look at the OECD. And you can argue that there are some very clear benefits from spending a tremendous amount, from kidney transplants to knee replacements to MRIs and others. But yet there's some challenges. Out of the 34 OECD countries, where the United States is, even despite having all expenditures, is 25th in maternal mortality, 26th in life expectancy, 28% in low birth weight. So again, we're sort of framing the issue leading to a policy change. So then you go down the history and says, what determines health? And you realize that, genetics is about 20%, healthcare is only 20%, but most of these social, environmental, behavior factors is the other 60%. So it leads us to this question of like, all right, so we don't spend that much money on social services, so do we need to do it? And it's really asking this question. And you look at ratio to social health spending, and again, you see the United States at the bottom on the right-hand side of the frame is the lowest spending of those. But yet, if 60% of factors are by those factors, you really have to answer the question of like, what are we trying to do? So again, U.S. for every dollar spent on healthcare, 90% is only 90% is spent on social services. Compared internationally, $1 spent on healthcare is $2 spent on social services. You're also going to bring it down to a local level. Again, we're framing this issue, setting the stage using some data, but framing the issues and really making it real for a policymaker, decision maker. So you can see these are the better outcomes. And statistically, we know this, and data-wise, we know this. We can also compare to the international ones. Like countries with higher ratio of social health spending have statistically better health outcomes. So we know all this stuff. We also know the evidence tells us about what type of social services produce the best health-related outcomes. So, we've just framed our issue, but now we have to decide what is our ask. And so we have to frame our goal. And our goal would have to be framed as, do we want to actually change a policy? Do we want to introduce a new policy, a new legislation? Or in a sense, are we asking just for a current change in the operations or the administrative of a current system? So that would really be the formation of a particular goal within a US-based one. If we look at a similar type of case international, we're going to take Denmark. And so Denmark, in a sense, started with really the question. Again, this is just framing the issue. So it's like they're really talking about what's the optimum integration of advanced practice nurses into Denmark's health system. But really, it's really to strengthen its primary care. And what are the projected improved health outcomes and cost savings? Again, they're already thinking about the cost savings because it's really governmental dollars that really drive this. So that was really the question that they started off with. But then they went back. And again, remember, you have to frame this within history and context. So you're looking at, the economics of it. 300 billion GDP, 48 billion spent on health and human services, 36 billion spent on 10% of the population, where they call them sort of the chronic disease or the repeat people that come back to the hospitals. And then, broke it down in terms of what other systems. They've got 5 regions, 98 municipalities, 88% live in urban areas, 3 delivery systems. Again, we're framing the issue for a policymaker. And then we provided a little bit more of numbers. So they've got 3,500 general practitioners. They've got 5.7 million Danish citizens, 2 million with chronic disease, and 570,000 are the high utilizers. Again, frequent context. So again, a policymaker, before we were making a recommendation, you're framing it for the policymaker. You're doing most of this work. And then you maybe look at trends. So you can study sort of the trends within the Danish healthcare, could be any country, and saying what's currently happening. And one of these big things for Denmark was, they had this amazing data system, but then for political and legal issues, it resulted in a collapse. And therefore you saw a 36% decline in preventive services. They were then, patients with chronic disease were often more managed by OOA or out of office hours. So you're really setting the context. And then you in a sense, after the analysis, you put it into what are the challenges? What are the primary challenges? Which means that healthcare costs are going up because of emergency room or hospitalization, to general practitioner shortages in rural areas. And you've got your secondary ones, which is sort of these data systems that may be there, or cross-system incentives in terms of are we working towards healthy patients, or are we working towards healthcare transactions, something to that extent. But ultimately, you're moving this with this idea. You're summarizing with the demand of the trends. So we've set that context. So for Denmark, they have to now make the next question of saying, are we addressing this in a policy change? Are we introducing a new legislation, changed legislation, Or is it really just up to the Denmark system to take all this idea for current system change? And that is really the ask. So with that, I want to move it towards healthcare. And again, Charles and Jose will ask for your commentary first. So these are drafts. This is saying the network TUFH has decided that it wants to look at global healthcare in 4 pillars. The first being social accountability, the second being population health, the third being a community approaches, and the fourth being interprofessional education. But so we have to, in the same thing, set the stage, and we have to say what would ultimately be our goal on a global level that then it can be translated to a national or regional level. So the draft social accountability problem is, in spite of a growing worldwide momentum in favor of the concept of social accountability and some outstanding achievements to implement it, there still remains a large gap between good intentions and institutional formations. So that's kind of in brief the problem. Maybe the goal might be, higher education training institutions adopt or are mandated to comply with social accountability accreditation criteria. And maybe that's the goal. So it's maybe not it could be a policy goal or it could be a systems goal. So I will stop there. And Charles, would you like to go first and provide commentary?
Okay. Well, I think we are staying in the I would say in the southwest corner of that diagram with the 4 squares. Meaning there is a lot of attention, public attention to the issues we are trying to move forward. I'm thinking about social accountability in population health and etc. and the 4 pillars, but there is still it's not seen as a priority by the decision makers. And I'm saying that because I see that there is a lot of attention to those key issues worthwhile, and still there is not an effort at the highest level at policymakers to make it really work. And I think it's important for us to know from where we are talking, what is our position on the chessboard. If we are education institutions, all right, so we know where we are, and we're not controlling the whole platform, but we are just an element on that chessboard. And I think it is important that we very early are saying and spelling out clearly what are our expected outcomes. What we want is, I think, four key outcomes. And I consider that as a sort of compass. One, we want quality of healthcare. We want to have people having their problems being solved in a way that is consistent with dignity and consideration for the human being. We're not just looking after an organ or a tissue, but after a person. That's quality. Second, equity. We want everyone to have the same chances of that attention. Third is we need to be relevant, meaning that we have to understand the underlying factors, why the things are the way they are. And now those are all the social economic determinants. And finally, I think we have to be cognizant by the fact that healthcare is a very complex undertaking, and so we need to be very cost effective in everything we mention. Now, all right, so those are the values, and I think there is a lot of attention on that from the public point of view, and at least our public, I mean education institution. And if I go and follow your diagram, Nick, I think that we have also articulated in a policy brief what are the social and economic impact. That has been documented, I think, in speeches, in publication, and briefs of all kinds. And still, there is no policy determination, decision-making process going on. The reason is, and I think the world is divided among, different stakeholders, and some are opposing change and some are willing to facilitate change. But regarding social accountability, for instance, of academic institution, as we think that when we meet people in different education institutions, even the higher ones, they believe that the values we just mentioned are the ones we should pursue, but they feel it's difficult to make it happen. And I think it is extremely important for us, and I think you mentioned that, that we line up all the arguments why we should do that, why we should meet all those values, and provide the argumentation. You're mentioning about calculation. We are not good in putting figures in terms of dollars, but we are certainly better in having qualitative indicators, and we certainly can demonstrate that institutions that do follow the rules that we just mentioned have a greater impact on the four values we mentioned. So, in summary, I think the time is quite appropriate because there is enough consciousness worthwhile that change has to happen. And worthwhile, what is happening? People are living longer. Citizens are more aware about what is possible because of the communication facilities. The health interventions are very costly, so we have to make some very cost effectiveness analysis, and the services in healthcare can be reconsidered by reallocating different tasks to different peoples. In a summary, we have enough reasons to believe that the world is ready for change. It's now a matter of articulating that in a list of arguments and being smart in advocacy at the highest level. I would finish here for a moment.
Thank you so much, Charles. And let me hand it over to Jose and briefly just reminding everybody about the topic, which is really we're talking about social accountability, the problem, and this particular goal. So, Jose, would you like to comment?
Yeah, I'm going to take a little bit of a different approach, in the sense that I totally agree with Charles in all the points, but I want to be also a little bit provocative, even if it is not my role from PAHO. But when he was talking about this is the appropriate time, I believe so. But I want to make a couple of points. The first one is, this time it might be appropriate because, for example, there is a kind of reassessment of the idea of primary care. Okay, everybody's talking now about the Astana Declaration, and we are getting the flags out again and again and again. One thing that happened is that it's 40 years after the Alma-Ata Declaration. And universally around the globe, the idea didn't develop as we expected. And my question at the moment is something like that. If during 40 years, we weren't unable to develop this idea, why now is going to be the moment, okay? And I will say the same, for the idea of social accountability, in the sense that, it's a great idea that we have been trying to, defend and develop, and we talk about advancement and that, and I think that this reassessment that we are doing at the moment, it has to be also very critical about why it didn't work, what is going to work now. And in that sense, I think that there is two differences that we had to make. One is that there is a great heterogeneity in the different regions of the world. And when you talk about this idea, you can see that I have some focuses and countries that they have been advancing on that. Okay, like I will say Canada, the United States, Australia, New Zealand, a few experiences in the Philippines, South Africa, little bits and pieces in Europe in a different context because we resolve the problems with the determinants of health and primary care in a different way. But at the end of the day, you see what we have is some examples of some places where all these things had been working. For me, the great advancement was that after 2010 and with the consensus and that, this was put in a bigger map. But I can tell you something when you examine the situation, for example, in Latin America or the Caribbean. When you do a mapping of the successful stories on social accountability, you have a lack of dots all around Latin America and the Caribbean. So you go to Asia or Africa, etc., etc. So this is one thing that I think that we have to really consider on that, because when I go to your squares and that, I think that, you know, in general, the issues does not have a lot of public attention. Even if we believe that they are having a lot of attention, what we are seeing, or I think that we are seeing is, you know, advancement of the discussion with some successful examples in some countries, okay? And of course, for example, this is not a priority whatsoever in many of the countries of Latin America, just to put the example on that way, okay? So it's true that it's a moment, and I really believe so, to create and go back to these ideas of the policy briefs and trying to go after the politicians and all that kind of thing. And Charles and me, we were mentioning before the possibility of the idea of having something about accreditation in this region. And the idea is this: I don't think that the evangelization of the idea of social accountability is going to work. Unless we manage that the politicians and the institutions go forward on that, and for that they need some incentives, this is not going to move. And also I believe that the driver for moving the idea of social accountability, it will be accreditation. Maybe I'm totally wrong, but I really believe that unless the medical schools in the region will see that inside of the accreditation processes, this is not going to advance more than we are doing. So if you ask me what I will put all my efforts, and that it will be doing a lot of advocacy, you know, at the high level, and this is where institutions like PAHO or other institutions might be of any help. So I try to push this forward on investment, on primary care, because social accountability and the practice of social accountability in medical schools, one of the ideas is it will be the creation of doctors that will go and work in primary care, especially in underserved areas and with vulnerable populations. So that will be my idea.
Thank you so much. So I'm going to turn it over to some of our participants, and we'll start with Aricia.
Hi, everyone. Great discussion so far. I think a value added to the discussion is as well how to implement it, how to make people take action is the value of a multidisciplinary team. It will not work if we only have one side in health policies pushing it. We have to tackle it from all ends, meaning to include all of the interdisciplinary workers that we have, the nurses, the midwives, the doctors, the specialists, the ecologists, the economists, everybody involved, so that they're all pushing on the same people and the same politics that we need to move forward. So I think there's a value that we have to look at when we're rethinking this, and as you were saying, rediscussing, looking at what didn't work and what we should change so that it would work, is the value of having different people from different professions, different ages, and different cultures involved in the discussion, as well as making sure that whatever policies come out of it, the cultural factor is also implemented, because as Jose was discussing, that social accountability is not seen as a priority in Latin America. That needs to be taken into consideration when you talk about something that you want to implement in that region. What works there will not work in Africa, and what works in Africa won't work there. So the importance of looking how to use and what kind of incentives per region should be used might help as well in pushing that forward.
Thank you, Aricia. And Stuart, would you have anything you'd like to contribute?
Hello, I'm Stuart Menon. I'm in Sao Paulo, Brazil. I used to be a network member in the 80s. and I stopped in the late 2000s. I was very involved in the network in its early years. And I've been working in Brazil for the last 15 years and around the world. And the essence of the issue that I see is a failure to understand this as a complex adaptive system. You're looking at it as a problem that has a solution if you find a root cause and then address it. I don't see a root cause in this problem, even though 60% of it is social determinants. But social determinants is highly interdependent and so the system. So I want to ask the question this way: why isn't the system responding in the way you want? And the question would be that it's a complex system and it's following a set of its own patterns. So complex systems exist in patterns, and patterns occur because of the way individuals behave, small numbers, local. Patterns are created by local behaviors. Local behaviors create patterns, and those patterns can be understood through simple rules. Behaviors, everyone chooses to go to the hospital for an injection. So the hospitals stay as the primary care place. So people's behavior is based on their own interpretation of simple rules, which they either are implicit or explicit. They're either aware of them or not. We should be looking for the rules that create the situation today and not be making arguments. In my experience, argumentation to policymakers is the least effective pathway of all the strategies. That they're not interested in your arguments. They listen politely and go on their way because they're playing by other rules. And the system is not coherent. In other words, it's not a self-similar or fractal system. It's fragmented. So how can the system become more coherent such that the forces and changes and movements are happening at every level? The personal level, the family level, the community level, the city level, the municipality level, the areas around, the regional level, the national level, the global level. When the same kinds of thinking is happening, and the context can vary, but the thinking affects all contexts, you move towards a coherent system. And I haven't heard any of that here at all. I've heard argumentation about what we think, but I haven't heard what other folks are thinking. So I've also heard, this is kind of a critical analysis in the sense that I can make a proposal as well. What I've heard is there's three questions that I ask as part of human systems dynamics. That is, what's going on? And you've got the data about what's going on. You stated that we need more primary care. It's still not happening. The medical schools are not responding. And then the last place I would look for any meaningful response would be a medical school, because most of the medical schools are taking elite class students and they're not interested in working in primary care. Look at the data. And my feeling is that, and the now what do you want is a policy change, but the middle section that's completely underdeveloped in the thinking is the so what does it mean for me as a human being? So what does it mean for those of us on this call? So what does it mean for those of us not on this call? So what does it mean for the people that don't go to medical school but work for a living in different ways or don't work? What does it mean for people in the developing world? I don't hear this discussion. You can cite data, but the data is so far away from meaningfulness to people that the distance between the data and the policy and your actions is too big to be effective. And that's why I think things fail. There needs to be more accessible action. The action has to be within reach. It's too far away. And so I would propose that we look at this whole thing is a complex adaptive system, and not just say it's complex and whatever that means to you. I think complex adaptive systems have specific ways of behaving and acting, and you can move them by looking at certain conditions. And I don't think that's part of the dialogue right now, and I would like to be able to add that.
So I want to say thank you, Stuart. I think that's a great framing, and I think it frames probably better than I did, sort of like why we're doing even this training, and saying is like, we don't have all the answers, but we have to start somewhere. And part of it is,
well, if you don't have the answers, you need to have questions. You're never going to have all the answers, but it's the questions that make a difference. And I'm not sure we're asking questions that move us forward. Yeah.
Makes sense. Well, let me turn it over to Jacques, who's been waiting to say a few things. And so, Jacques, would you like to go?
Yes. Well, hello everyone. I'm just listening to all those very interesting comments, and I think that this overall issue of this thematic is really, really important. Thanks, Nick, for your introduction, because, well, as a public health practitioner, actually, I'm always actually really concerned with this, how we could actually bridge those boundaries between the academics, the policymakers, the community as such, leaders within the community, those managers for health services and so on. And I think the social accountability framework could perhaps make a change in the long term. In the short term, of course, we need to be very realistic. We can't change things de la noche a mañana, as we say it in Spanish. And I think that if I remember what we were discussing very recently in Rabat, in Morocco, when we were this RIFRES meeting where Charles was there, I think there are a lot of elements that could drive us to those aspects for changing, not really our rules, because the rules are there. So we need to deal with those rules, but we can make a change. One of the aspects that I would like to bring as an asset, I realized that very interesting experience that we could actually build on were when the academic world has become actually a driving force for change. In other words, we say it in Spanish also, the vanguardia. I think that universities should be really before where the society is, and probably we lost this. And I think that what Stuart was mentioning, that what could we expect from Faculty of Medicine is right in a way. But in another way, I think we need to focus on those institutions that were able really to drive forces, like in the Philippines, for instance, in Mindanao, or there are a lot of experience that Charles could actually share with us. So I think that I'll take this. I think that one of our main obsession should be how we could actually have those institutions, especially academics, to be examples, to guide actually societal change. And what is interesting with the gradient of social accountability is that there is room for everyone in that. But of course, we need to face a lot of resistance and a lot of opportunist actors, actually. So I think that one focus is how we could have academic institutions in the process of change, and then give them tools so that they could actually move ahead. And Jose Francisco just enlightened me when we were together in Ireland to this WHO conference on human resources for health, when he just shared precisely a model, those 6 variables on which we need to work on, like the students, the professors, research, of course, governance. I'm just thinking about the other one, of course, impact on society and so on. So I think that if we get into a process where we could actually build some metrics, that was the whole idea of ISAT that Paro was pushing as an agenda. And I think it's very relevant because we did this process, Jose Francisco, with our people at Laval University in Quebec City.
And we just did our workshop in Rabat 3 weeks ago, and it was magic. It was magic because the people realized that when we could actually evaluate ourselves, where we are for the students, where they come from, those students, first thing, and what should we do about this? Professors, is there any diversity in that? Research, what are the main topics on which we are working? Even biomedical research could do something about that. The governance issue also, how we could have our leaders, academic leaders, to become really promoting change for that. And of course, our impact with the community. Like at Laval University, we're working a lot, very hard on indigenous communities, having the leaders, indigenous leaders, to work with us and listening to them.
So Jacques, let me interrupt so we can get to, let me frame one more thing, because we're just going to basically have a chance for one more round. But again, remember, this is just the beginning of this conversation. You know, the end goal for the Network TUFH is to frame this up through the conference, and then at the end of the conference, shift this into actual policies and actionable steps that people can take back to their own regions, their own countries. But I wanted to frame I'm going to go through, just frame these other questions and then hand it back to Charles and Jose for commentary, and then we'll open up to the community again. But, you know, the second pillar that we've been really working with is population health. Particularly within population health is, you know, well, I'll just frame it, and then what we think is maybe the goal, which was many of you started talking about. But public demands, increasing cost of healthcare services, the recognition of social and environmental determinants of health, the decline in primary and preventive care, along with the increase in global chronic diseases, population inequity, and poverty calls for establishing a global recognition for all members of the health team. So that's kind of the framing, at least the start of what we're thinking. And then, you know, if the goal, which is really helping us move to concrete actionable steps, is to say, you know, how do we embrace these community health workers so that they're provided with a training certification, the vehicles to become health, and then maybe attach it to healthcare reimbursement. So that's the initial thought. So I'd love commentary on that. The second one is really these community approaches. So, you know, we're effective approaches to serve and engage remote and rural, indigenous, migrants and refugees, women and elderly populations, you know, which are often contrary to mainstream health policies because of their exception rather than the rule, are often ignored, not included or recognized in global, national, or regional policies and practice and inform mainstream practices. So, you know, what we are thinking that our goal is really to say is, you know, taking those same populations, and we want them to be included and recognized in global, national, and region policies and practice recommendations. So very connected. And then the last one is this interprofessional educational issue. So, you know, going back to social accountability and almost the same framing, despite the recognition that interprofessional collaboration in education practice is an innovative strategy that will play an important role in mitigating the global health workforce crisis, healthcare professionals, they do not necessarily convene regularly, resulting in less than optimal collaboration. So, you know, initial goal might be, you know, at all health conferences, we maintain a balance of registered medical, public health, and population health participants. So there's a balance. So it's not just, you know, the same people talking to each other. So, you know, those are at least, again, the initial drafts that we're framing this. But let me turn it back to Charles for commentary.
Actually, the 4 pillars is another way of saying that we want to respond as effectively and sustainably as possible to people's health needs. And this is complex. And we mentioned that, and I heard Stuart saying how complex it is because we have so many determinants that we have to take into account, and then so many stakeholders that have to take part in all that. So it is indeed complex, and it will not happen at once, but we have to got a strategy to go into the system by a certain entry point. Now, the academic institution is an entry point, but it's not the only one. And I hope we have the same understanding of social accountability. It's not just, you know, mixing with communities during the training and things like that. It is really understanding that we need to go beyond the usual things we do and follow up, including partner with other organizations and other stakeholders so that at the end of the day, we can make a difference. Now, but you see, we're talking about data and arguments and proving things and bringing the evidence with figures. I'm not sure this will happen with data and figures. It is just like human rights, right? Now, human rights, we have now a universal understanding of what it means. Even countries might be a little bit reluctant to adopt it, but you know, in a way, it is something that is globally understood. It's still not practiced, and so we wonder why things are well understood and not practiced. And social accountability is a little bit of the same sort of concept. It's an overarching principle that is humanistically right, but on which we are not making great progress. And when I speak to my medical doctor, who's a good friend, and I'm asking, why are you not doing different things than just waiting for caring for the people waiting in the waiting room and being, you know, more community involved and do health education to the public, etc. And he says to me, why should I do that? I'm not interested. I'm not paid for that, and nobody asked for that. So it is true that social accountability has made progress in academic institution worthwhile. At least there is interest, and there are different degrees of implementing the concept here and there. But we have not taken the risk to talk to other stakeholders, as I just mentioned, the health professionals, you know, and not just doctors, but all the health professionals in their own capacity. We have not able or daring to talk to insurance companies or pharmaceutical companies. And so there is a time where we will have to have the courage to address them and eventually confront them and see how we can have the different stakeholders progressively move towards that central values of responding to people's needs. I would oppose three sort of action. First of all, I think that international organization, and I'm talking about the World Health Organization where I have worked for many years, has to be more daring, courageous, more engaged. It's not enough to have statements and resolution. I think they have to go to the policymakers and being more gently aggressive in proposing things that should change. Second, we have to go to our national leaders and make our points too. And of course we have countries like Canada and several others in Latin America where national policies are very much favoring the progress we're talking about. And third, as I said, although I may agree with Jack that academic institution might be the avant-garde of something, but it is very important that we confront ourselves with the other stakeholders, the professional association, the healthcare organization, the public health experts, etc., so that we can progressively build a common vision and a common understanding of where we should go together.
Thanks so much, Charles. That's a great framing. Let me turn it over to Jose Francisco.
Stuart, I love the way that you approach it. In the idea that, you know, one of the things that I think that we need is just to try to explore different ways to frame all the things that we are talking about. And in that sense, I want to make a statement talking about, and sorry for concentrating in Latin America and maybe in Pajo and the situation, but this exercise that we are doing at the moment, we have been doing it internally here for 2 years since I arrived, okay? Because, you see, we have to develop this strategy, and we fought very hard to put a priority line dedicated to education of health professions. even if that sounds very obvious, and that you can imagine the amount of effort that we had to do for this institution and my own team to accept that as a part of a priority. Okay, once we manage to get that education of health professions need a transformation, we have to decide that there are many different things that you can do around that. Okay, and along the discussion, we manage to prioritize two things. One is, if we look at the major problem that we have in this region and in many other regions of the world regarding human resources for health, there is a headline. And the headline is saying, health systems are struggling, really struggling to bring people to work in primary care, and especially for vulnerable population and underserved. That's the heading of the newspaper. We can dedicate, our lives to doctor houses and do what Harvard or Yale or other big institutions are doing, creating super specialists. But we decided to concentrate on that, and that's the point, and the area where I think that the network and PAHO at this moment, they have a common ground. But a common ground, if we are able to define a common objective in a very clear terms, because if not, we are going to go and just be lost on the sea of the health problems that everybody has. Okay, and in that sense, one of the things that is very, very particular that it has happened, and Charles, you are very conscious of this. Okay, for example, it's very interesting to see how WHO or PAHO had been abandoning public health in the sense of the old traditional public health. Why? Because everybody is doing public health. Even they make disappearing the post related to public health, even if they talk about, the essential functions of public health. Why? Because everybody is doing public health. The people in chronic diseases, in infectious diseases, the gender people, all the variations that you have, okay? And I really believe that, what we are talking about, what it will be, the goal from the network and from PAHO in this framework that I'm putting about is when I decided that there are these pillars, that I think that, maybe there are other things to do, and I agree with the Stewart about the need of assess the systems, the complexity of the systems, and explore on that. But I will challenge him in the sense that we need to explore the complexity of the system, but being humble in the sense that, we have to think, in a broad term, but we need to work specifically and fast, so be up to certain points. That will be my idea. And when Nick is defining those 4 approaches, one of the things that I was interested in was to see that, 2 of our pillars, we have decided to concentrate on social accountability and on interprofessional education as the 2 major areas that we are trying to promote to advance on these ideas. And maybe we are wrong, but our analysis of the system at the moment, and we probably are wrong, okay, have decided that at the moment and in the framework, in the actual framework that we have in Latin America, that is very complex, and this is for you, Stuart, living in Brazil, you know perfectly well what is happening in this region. In this region, there is now a very serious and dramatic assault on the idea of universalism. Many countries are having a big recession
Francisco,
on social policies.
So, part of this is, again, thanking everybody sort of this process, and Jacques and Stuart and Aricia, if you have sort of final 10 to 36 commentary, is I think this conversation has led back to this original thing, is even though it's been said that the data and sort of logic may not drive policy, it's not that we still have to start in that process in terms of when we think about that. And so we still have to articulate it in this policy brief. The second part of what we're really moving towards is, well, how do you actually influence people to make those changes? So the May session is really going to be focused on this policy map. And that is really about influencing people to take action, make behavior changes or so. So this conversation will be continued in a month's time. We're hoping to engage additional people in that process, because that's where I think all of you led towards, and saying we've been doing this for many years, and yet we haven't necessarily seen the changes that we know make sense. So it gets back to this question, well, how do you do that? And, Stuart said, well, we have to start with asking the right questions. And he said, and yet to have the right economic as well as so this part is like, okay, we need to dissect this whole process. So let me, turn it over to Stuart and then Jacques for maybe last 10, 30-second comments, because we're out of time. And then I think Garcia left, and then we'll conclude and continue in May. So Stuart?
What you're asking for is a paradigm shift that affects the entire system. And I don't think medical schools are going to lead the way. So a paradigm shift affects everyone to move beyond the place where you're stuck and include the place where you were before. It doesn't exclude what happened before. So what constitutes a paradigm shift, and what are the conditions that create a paradigm shift? We're not talking about that. Second, explore complexity, yes, but I don't get an idea that there's an understanding of the underlying forces that affect complex systems, what holds them together, what tensions and energy come from difference, and how exchange is made. Those are the three conditions that influence complex systems. There's been nothing about that. And I feel like the paradigm you're in is not adequate to the problem you're facing, and we could have a much deeper discussion about this. And there is a way to act on all of this and move forward with a better understanding of what I'm mentioning. And that'll stop there.
Well, thanks, Stuart. And I think, maybe I'll connect with you offline, because you seem to have an in-depth understanding of this, and maybe we incorporate you into the second session, but thank you. So Jacques, we're going to send you with you the last commentary.
Well, in fact, briefly, I think that it reminds me this discussion about when I was with a colleague of mine at Harvard. He was on political sciences and was telling me that you people in public health, you consider that when there is no political will to move ahead, you think that we need to wait. And he said, this is probably where the work needs to start. And I think that for what you shared with us, Nick, I think it's an invitation just to make it more structure, or the way we could actually orient this paradigm shift that Stuart was mentioning. And of course, we deal with complexity. So I think that we need to move forward, and there's no other way than to be aware about a lot of factors that we need to really try to, I would say, to manage them and making things happening. So thanks.
Well, thank you, everyone. Thank you, Charles. Thank you, Jose Francisco. Again, this was the beginning of a conversation, and I think, as Jacques said, there is no other avenue but to move forward. Yes, we need to take a deeper dive into this. First step is, the TUFH, the network, is kind of using it as a platform to frame the issue, involve people in this process, hopefully capacitate them with the beginning knowledge and skills. But ultimately, we're leading towards, some concrete end-game policies and position papers at the conclusion of the conference that then will hopefully be tools and move the needle forward. So again, this will be continued in May. Hopefully everybody will join us there. In the meantime, we will take this video, editing it, and then we'll be sharing it with a larger community. So thank you for your contributions, and everybody have a good morning, afternoon, or evening, depending upon where you exist in the world. Thank you.
Bye-bye, everyone.
Bye.
Lovely to meet you. Bye.
Bye.
Thank you. It was a pleasure. Bye-bye.